Alright everybody, welcome to this lesson on lumbar drains. The purpose of this lesson is going to be to provide education for our open heart nurses on what lumbar drains are, why we use them, and some of the nursing interventions associated with taking care of the patients that have lumbar drains. So the main first question that you may be asking with lumbar drains is, why do we even use these? There's many reasons within the medical field on why we would use a lumbar drain for a patient, but in our particular environment, the reason that we would be using them is in the treatment post-op for either thoracic aortic aneurysm or thoraco-abdominal aortic aneurysm. So I'm just going to go ahead and write this out for you here. So over here we had our thoracic, and over here we have our thoraco-abdominal. This is going to be aortic aneurysm. So oftentimes you will see patients that have just undergone the thoracic or thoraco-abdominal aortic aneurysm repair, and these patients will come out with the lumbar drain. And the reason that we're using them, and there's one big main reason on why we do it, and that is to prevent paralysis. So ultimately our goal with the lumbar drain is to prevent paralysis or neurological complication, and the way that it does this is it reduces the pressure within the spinal canal. So in a little bit here, we're going to go over some of the anatomy, some of the placement information, just to give you a better picture of this process and how this is working. But for right now, just know that the reason that we're doing this is to prevent paralysis in these patients. And the reason that we're so concerned about this is it really is a major complication of having the aneurysm repair surgery. So, whether you're having the open surgery, depending which literature you're looking at, there's anywhere from 10 to 40% incident rate of paralysis or neurological complications post-op. But even when you look at doing the endoluminal approach, there's still an 8% chance of paralysis or neurological complications. So, it definitely is something that is well known, and it's something that we try to do everything that we can to reduce this risk for the patient, because we can save their life and catch this aneurysm, go in and surgically repair it. But one of the long-term serious consequences that could arise from this is paralysis or paraplegia. And the reason that these patients are at risk for paralysis is what happens is during the surgery, they do a cross-clamping of the aorta. And when they cross-clamp that aorta, then what this will lead to is spinal cord ischemia. So obviously we're clamping the aorta, so we're not getting perfusion to the spinal cord and other organs below the level at which the cross-clamp is. Ultimately, this spinal cord ischemia will lead to edema within the spinal cord. And so eventually, if untreated, the edema and ischemia can lead to the paralysis. So like I said, the information or the knowledge that this is a major complication following this surgery is not unknown to the medical profession. So there are things over time that we've developed and we've put in place in order to try and prevent some of these complications. And so some of the things that we will do in order to try and prevent these complications, one thing that they can do in the OR is they can put in a what they call a distal perfusion cannula. And basically this just helps to perfuse blood to distal portions of the body where we are not getting good blood flow. Again, this is something the surgeons are going to do intraoperatively. Another thing that they will do is just a general systemic hypothermia, and this is not a complex hypothermia. This is they just generally will keep the body cooler. By having the body cooler, there's less oxygen consumption and oxygen demand, which again can reduce the risks of ischemia. And a lot of times we'll see this move on to what we call deep hypothermic circ arrest. And this is essentially where they drastically cool the patient down and go into circulatory arrest, allowing them to do whatever they need to surgically in there, and they've greatly reduced the oxygen consumption that the body is using during this. This is something that we will see pretty frequently, and make sure that if it is something that they've done, that you find out the amount of time that they've spent in circ arrest. There are also some pharmacological interventions that they can do. They can give barbiturates, steroids, other things intraoperatively, again, to reduce the risks that are associated during the surgery. Also, intraoperatively, they can do intraoperative monitoring. So this would be monitoring the edema and cord pressure, some of the things intraoperatively, and this would be something that's being done intraoperatively by anesthesia while the case is going on. Another thing that we will see the surgeons can do sometimes is what we call reimplantation of intercostal vessels. And again, we'll talk about this when we get into talking about some of the anatomy, but once the graft has been put in place, the surgeons oftentimes can reimplant or reattach some of the blood vessels that will supply blood to the spinal cord at various points along the way. And so these are a lot of the interventions that can be done and oftentimes are used here intraoperatively to try and prevent complications and prevent paralysis in these patients. But the one thing that is frequently used and one of the most common interventions we'll see post-op on these patients is exactly what we were talking about in this lesson, which is going to be the lumbar drain. And the lumbar drain has really been shown to improve the neurological outcomes and prevent the spinal cord ischemia. Typically, we'll leave them in place for 24 to 72 hours, and it allows us the ability to monitor and intervene on patients who are at risk. And the lumbar drain is going to be a particularly important one for us to talk about because unlike all these other interventions that they do, those are all things that happen in the OR intraoperatively. The lumbar drain is something that these patients will come out with, arrive on the unit, and then it will be up to nursing to continue to monitor and intervene on these patients as appropriate. Alright, so now that we've talked about the reasons on why we would be using lumbar drains, let's get into a little bit of the anatomy and pathophysiology behind what is happening. So we're not going to go into a very complex and detailed discussion of the anatomy here, but I do want you to have a basic idea of what is going on. So, here we have our vertebrae, and here this is the makeup of our spinal cord if we were to take a cross-section of it. We do have our blood vessels here and here, which we're going to talk about those a little bit more in depth in a second here. And finally, all this light blue in here, this is going to be our CSF, or our cerebrospinal fluid. And this drawing isn't 100% anatomically correct, but it gives you a basic idea of what is going on inside the spinal column. So now let's talk about the spinal cord blood supply, as this is really the meat and potatoes of why we end up ultimately using lumbar drains in patients. So back here you have the posterior spinal arteries. And you actually have two of these here. And then up here is where you're going to have your anterior spinal artery. And you only have one of these in front. The posterior spinal arteries are primarily fed by cerebellar arteries up at the top of the spinal cord, and for the most part perfuse their way down. If we look at our drawing over here on the right, you can see, that we do have, there is some collateral blood flow that will come from or in between the anterior and spinal arteries, but for the most part, most of the perfusion is coming down from the top. And so the anterior spinal artery is really important because it supplies blood to 2/3 of the spinal column. So the anterior 2/3 of the spinal column is primarily fed by the anterior spinal artery. Now again, if we look at the diagram on the right, we can see that as we work our way down the aorta here, that we do have what we call segmental arteries here and here and here. And again, there's more than just these three that I've drawn here, but this is just for the sake of simplicity and understanding what's happening. But these segmental arteries, they are intercostal and vertebral arteries that ultimately are branching off of a blood supply that is coming off of the aorta here, and they're coming in and feeding the anterior spinal artery to continue to feed and perfuse blood to the spinal cord throughout the whole length of the cord. Now, there are many of these segmental arteries that come off and feed into the anterior spinal artery, but there is one important one. They refer to it as the artery of Adamkiewicz, and it sits roughly about here. It comes out at around the T8-L1 area, and it's the largest anterior segmental medullary artery. Now, this one particular segmental artery, it feeds the lumbar and sacral cord, and this is really important because this is the section of the cord that is responsible for the lower 2/3 of the body. And the reason that we care so much about this particular segmental artery is that when we do stenting or surgery on these patients, a lot of times this particular artery can be covered and impacted by what the surgeons are doing. So again, we'll get to talking more about the consequences of that here in just a little bit. So now I do want to talk about our cerebral spinal fluid. And this will oftentimes abbreviate as CSF. And really, the CSF plays an important job because it acts as a cushion for the spinal cord and the brain. It's contained within our subarachnoid space. And normally, it's a colorless and a clear liquid. It is produced by the choroid plexus, which is in the ventricles within the brain, and typically the body will produce 500 to 600 mLs per day. So the body is constantly making the CSF, it's being reabsorbed and reproduced, but at any one given time you're going to have anywhere from 125 to 150 mLs of CSF in your body. So this is both between your ventricles within your brain and around your spinal cord in the subarachnoid space. Now that we've talked about the anatomy that plays an important role in understanding what is going on with our patients who have lumbar drains, I do want to talk about some of the pathophysiology in terms of what is actually going on and ultimately why are we having a lumbar drain. So again, as we kind of briefly talked about before, we have our aortic cross-clamping. And when we do that, it leads to spinal cord ischemia. Spinal cord ischemia leads to edema, and this edema can then lead to paralysis. And like we talked about, even with endovascular repair, there can be decreased flow due to a lack of collateral circulation, and that can also cause the ischemia that would then lead to the edema and then potentially paralysis in these patients. So even though we don't do cross-clamping of those patients, they still are at risk for the spinal cord ischemia, and they may also come out with lumbar drains. But to understand the process a little bit better, during the cross-clamping, we have the ischemia that takes place with the spinal cord, and this then can lead to damaged cells. And as we know, when cells are damaged, one of the things that will happen is they will swell, leading to the edema. And then this edema will then lead to an increase in our spinal cord pressure and a decrease in our spinal cord perfusion pressure, which both of these are things that we'll talk about more in depth here in a minute. But this increase in spinal cord pressure and decrease in spinal cord perfusion pressure is what ultimately can lead to the paralysis. And one more thing too is when we reintroduce blood flow, so when we unclamp the aorta, sometimes what can happen is they get a reperfusion injury. And essentially what happens with reperfusion injury is when reperfusion happens, that this can lead to inflammation and oxidative damage to the cells. And as we talked about, damaged cells here lead to edema, which then lead to more increased spinal cord pressure and decreased spinal cord perfusion pressure, which ultimately can lead to paralysis. Alright, so since we introduced these two terms over here, our spinal cord pressure and our spinal cord perfusion pressure, let's go ahead and talk about those a little bit because they are really the key to understanding what is going on here. So the most important of these two values is what we call our spinal cord perfusion pressure, and this we will see abbreviated as SCPP. And really what your spinal cord perfusion pressure is it's simply a calculated value that's going to represent the perfusion of the spinal cord. So really, if you think about it, it's very similar to our map that we look at for our blood pressure. We want to maintain above a certain level with our map to ensure that we're getting enough perfusion to our vital organs. The same thing is going on with our spinal cord perfusion pressure, our SCPP. We want to maintain a spinal cord perfusion pressure that's high enough so that we know that we're perfusing into the spinal cord. And the way that we calculate this out, so our spinal cord perfusion pressure is simply our map minus our spinal cord pressure. And typically our normal value for this is going to be a spinal cord perfusion pressure that is greater than 80 millimeters of mercury. And so like I said, the spinal cord perfusion pressure is to ensure that we have enough perfusion to the spinal cord. So the values, if you look at here, we have our mean arterial pressure, and we're subtracting out our spinal cord pressure. The spinal cord pressure is that pressure that's a result of the edema within the spinal canal. So in order for the perfusion of blood to take place, it has to be above, or it has to push against how much pressure is in the spinal canal. So however much pressure we're having exerted by our mean arterial pressure, it still has to overcome how much pressure is in the spinal cord. So we're subtracting that out and figuring out what our SCPP value is. And as long as that value is greater than 80, then that tells us that we are getting enough perfusion and blood into the spinal cord in order to prevent any further damage and hopefully to reduce the risks of any damage that did take place during surgery. Some important things to know with our spinal cord perfusion pressure would be that acidosis can lead to an increase in our spinal cord pressure, which then, looking at our formula here, an increase in our spinal cord pressure would lead to a decrease in our perfusion pressure. And then hypotension can lead to a decrease in our spinal cord perfusion pressure. And if this tends to be the case and what is leading to our decreased spinal cord perfusion pressure, then a lot of times what we will do is increase our systemic blood pressure by using pressors. And again, the whole purpose of that is to increase the blood pressure, which will increase your MAP, and that will provide enough pushing power to overcome whatever our spinal cord pressure is to ensure that the end result is that we're perfusing the spinal cord. And finally, the most important thing to talk about here for the purposes of this discussion, I'm going to go up to the top here, is to talk about our lumbar drain. So for one, it allows us to monitor the spinal cord pressure. But more importantly, it also allows us to drain CSF fluid. So this allows us to decrease the amount of CSF. And by decreasing the amount of CSF, this is going to decrease our spinal cord pressure. And ultimately, again, looking back at how we calculate out our spinal cord perfusion pressure, we take our MAP minus our spinal cord pressure. If we decrease the spinal cord pressure, then we are going to be increasing our spinal cord perfusion pressure. And ultimately, that is the whole goal in having patients with the lumbar drain post-op, so that we can monitor that pressure and drain CSF fluid in order to ultimately give us a good spinal cord perfusion pressure, allowing perfusion to get to the spinal cord, preventing complications, and hopefully preventing paralysis. All right, so let's move on to talk about some of the complications that come from lumbar drains. So there are a few main complications that are really important to watch out for. The most important, I would say, would probably be our intracranial hypotension. And this is going to be the result of excessive draining. So like we talked about, there's 125 to 150 mLs of CSF in your body between your brain and spinal cord. So there's not a lot of fluid that is available, and if you drain off too much of it, it can lead to certain complications. Some of the things to look out for with this are going to be headache, nausea. You can also have abducens nerve palsy, so this is going to be cranial nerve 6. And essentially the abducens is what controls the lateral movement of the eyes, so that side-to-side movement. So sometimes, and this often can be an early sign of neurological complication from overdrainage, you'll see the eyes will tend to move inward, almost kind of a cross-eyed look. This is something that's going to be easy to assess even if you have patients who are out of it, non-responsive, sedated. And the last big thing to be concerned with excessive drainage is going to be our intracranial hemorrhage. And this can manifest itself as either a subdural hemorrhage or a subarachnoid hemorrhage. And so what can happen is if you drain off too much CSF, the decreased volume of CSF causes the brain tissue to shrink. And this shrinking of the brain tissue can pull at blood vessels that are located within the skull. And if that happens, or there's too much going on, that this can sometimes lead to a rupture of one of those vessels. And this is where we could look at the complication of subdural hemorrhage or a subarachnoid hemorrhage. And as a result of this, we really want to try to limit the amount of drainage to 15 to 20 mLs per hour. In fact, we'll get to talking about the times that you would contact a physician, but oftentimes in the care set, the order that they will put in is to contact them if you have greater than 10 mLs of drainage in 1 hour. And signs that you would notice that we have either a subdural or subarachnoid hemorrhage going on, one of the things that you may notice is either bloody or pink CSF drainage, because again, we talked about normally that's a clear, colorless fluid. And then also any other neurological changes similar to what you might see with a patient having a stroke. So the next complication that we're going to be worried about with the lumbar drain is going to be infection. And obviously, lumbar drain is a pretty invasive thing. It's a catheter that's going from outside the body all the way into the spinal cord. So obviously the things that you're going to be looking for, your increased white blood cell count, increased fever. Another complication with the lumbar drain is on removal. Sometimes we can have a fractured catheter. And so this is simply going to be inspecting the catheter after removal by anesthesia to ensure that the tip is intact. And then finally, another big complication that we can be worried about, and this can happen both on insertion as well as post-op, and that's going to be bleeding or hematoma. And so the important things to look for with this are going to be lower extremity deficits, so if your patient is awake and responsive, you want to be checking their motor strengths and sensations. And if they are unresponsive, then we also want to be looking at their deep tendon reflexes. Sometimes we can also see a loss of either bladder or bowel control. And so with these, it's really important sometimes that we want to try and avoid anticoagulation. Typically, this isn't a problem with post-op patients, but just know that if the lumbar drain were to stay in for a long period of time, this is something that we want to be having a conversation with the physicians about. It certainly is not always contraindicated, but at least initially and early on, we want to try to avoid the anticoagulation. And ultimately, if we see any signs of bleeding or especially hematoma, it's going to be imperative that we get a CT or an MRI as quickly as possible, because really we have less than 8 hours in order to fix the problem. So it's important that you're on top of your assessments, and as soon as you notice any kind of change, that you contact the provider in order to see if there's further intervention that we need to do. So those are really the main complications that we'll see. So let's kind of talk about some of the things that we can do to prevent some of these complications. So the first of these would be to assess the system integrity. And this would be to assess and make sure that everything is working properly in order to prevent excessive drainage as well as preventing infection. We want to make sure and have a clear dressing at the insertion site. And again, this allows us visualization in order to be able to assess the insertion site. You want to maintain that dressing integrity. And again, this just goes back to reducing complications from infection. And again, to prevent infection, we want to minimize opening and closing of the system. You want to avoid overdrainage. You also want to be performing frequent neurochecks. You also want to evaluate the patient tolerance. And also, very importantly, is patient and family teaching. And hopefully in doing all this, we can reduce the complications that can arise in these patients that have lumbar drains. All right, so now let's go ahead and move on to Banner's policy concerning patients with lumbar drains. So if you go onto the intranet and you search for the policy lumbar cerebrospinal fluid CSF drain monitoring and management, and this is policy number 15058, and in this policy it fully lists out and explains all the aspects of Banner's policy in regards to lumbar drains. So I will advise each of you to go onto the intranet and print out this policy so that you have a copy of it and you can review over it. But I do want to cover a couple of the important things. The first thing is the placement or the removal of a lumbar drain is to be done only by a provider, and it's supposed to be done under sterile conditions. Also, you're going to need informed consent for the procedure. Next, the setup, management, and care of the lumbar drain system is only to be performed by validated RNs. And we do have a validation sheet in order for you to get signed off on in order to be a validated nurse to take care of lumbar drains. To go along with that, if you are going to do any CSF sampling, so whether sending a sample down to lab or troubleshooting by accessing or withdrawing some CSF fluid from the system, there is a separate validation form, and this should only be performed by RNs who are validated in this procedure. So again, that's a separate validation form that we will get you signed off on in order to be able to sample CSF fluid. Next, and really important, is that the RN will never, you do not flush towards the patient. There are troubleshooting techniques that we will talk about in a little bit that you are able to flush in other parts of the system, but you would never flush or give medications in the direction going towards the patient. So even if you have a provider or physician who is telling you to do this, know that Banner policy says that we do not do this. And the final thing that I want to talk about here is, again, anytime that we are accessing the system, we want to treat it sterilely, so we're always going to be using sterile caps. And whenever you do access it, you are going to use betadine with a good 30-second scrub. You do not want to be using either CHG or alcohol. CHG contains alcohol in it, and alcohol can be very irritating to the meninges. So anytime we access the system, we do not use CHG or alcohol. We only use betadine, doing it sterilely with a good 30-second scrub. So like I said, this is not everything that's covered within the policy, so make sure that you print out a copy of it and review over all the information that's covered in there. So now let's go ahead and move on to talking about the actual drainage system that we use, which is the Codman drainage system. So for right now, I am just going to do a real quick talk through of some of the management of the entire lumbar drain system. I will be putting together a separate training video that will cover all the different parts of managing the lumbar drain system. So I do want to talk about the management of the lumbar drain system. I do want to talk a little bit about the setup, leveling and zeroing, recording our values, draining, as well as the removal. But like I said, there will be a separate video that will really show you in depth how to do each of these different parts. I do want to talk about some of the things though on our drawing just to kind of make sense of it here. So if we look over at our patient, we do have the catheter that's coming out as well as the attachment point to the lumbar drain system. Down here towards the patient, you are going to have a stopcock as well as you'll see an access port coming off of there as well. This is what we will refer to as the patient stopcock. If we travel farther along on our tubing, we'll first come up to another stopcock up here. This is what we'll refer to as our panel stopcock. To the right of the panel stopcock, you'll see our laser level, which is going to be used to ensure that we have this at the proper height. And to the left is going to be our transducer. And just like the transducers that we use for our other pressure monitoring, there's going to be a cable that comes off here, which we attach to a cable that will run all the way to our monitor here. Continuing along with the tubing from the panel stopcock, that will work its way over to the top of our drain, which is this big chamber here. Down at the bottom of the drip chamber, we have another stopcock. And this is the one that we use to control drainage that goes down into our collection bag. Also on the drain setup itself, you'll notice a blue and green section here with numbers and values. On the left hand side, the numbers in the blue section are going to be measurements in millimeters of mercury, and on the right are going to be measurements in centimeters of water. I'll talk about some of the differences here in a minute, but typically when we are setting levels of the lumbar drain, the orders are going to be given to us in centimeters of water. So it's going to be important that you are using the correct scale. If you go down to the middle of the scale, you'll see there's a red marker that is used to determine what level you have your drain set at. So the first thing we'll talk about is the initial setup of the Codman lumbar drain system. Sometimes the system will already be set up by anesthesia and the OR staff, and they will come already set up and ready to go. Sometimes they will just come out with their lumbar catheter capped at the end, and it will be our responsibility to set this up and get it hooked up to the patient upon arrival. If they do come with it already set up, before anesthesia leaves, you want to make sure that everything is set up correct, that it is draining. You want to check your spinal cord pressure, look at the color and consistency of your CSF fluid and the amount of drainage that's in there, and verify all that with anesthesia before they leave. So for the actual setup of the system, know that you're going to need at least 2 people to do this. And let's talk about some of the supplies that you're going to need in order for the setup. And if you know that you are going to be having a patient that's going to be coming back with a lumbar drain, just go over to trauma and grab their NeuroCart. Sometimes it's on A-Pod, sometimes it's on B-Pod, but go ahead and grab that NeuroCart and bring it over because it's going to have everything that you need inside of there in order to get this set up. But the supplies that you're going to need out of that NeuroCart, first off, you're going to need the Codman external drainage system, the setup itself. You're going to need specifically an ICP transducer. And this one, again, it's going to be in the NeuroCart, but it's going to differ from the ones that we typically use for all of our other pressure monitoring. It's not going to have the pigtail on there in order to that you would use to flush your pressure lines. It's going to look just like a regular transducer without the pigtail on there. Next, you're going to need preservative-free sterile saline. And this is not the saline syringes that we keep in the bedside. You're going to need the actual sterile saline that come in the sterile packaging. This way, both the saline as well as the outside of the syringe will all be sterile because you will be doing this process sterilely. So on that note, you're going to need sterile gloves and mask. You're going to need your pressure monitor cables. And this is going to be both for your art line as well as for your lumbar drain setup. You're also going to need a separate IV pole. And lastly, the laser level, which is going to come from the manager's office. If there's not a manager there that day, then we can also get the laser level from the 10th floor. So again, I'm going to reiterate, it's really important that we do this setup and we do it sterilely. And this is why you're going to need at least 2 people so that the second person can be your set of hands to give you things that you need once you put on your sterile gloves. So once you have all the supplies that you need, in order to set this up, first you're going to take the entire drain setup out of the box and you're going to attach it to the IV pole. So this is where your second person can come in, that you can hand this off to them. They can attach it to the IV pole, and there's going to be a twist clamp over here on the left side that we use to twist and tighten it down onto the pole. There's also a string that's up here hanging off the top of it. This is important. You want to secure this to one of the hooks or somewhere on the IV pole, and this really just serves as a backup securement spot just in the event that that twist clamp were to fail. But our primary means for securing this is going to be that twist clamp right here. So next we're going to take the transducer out of the packaging, take off the extra stopcock and tubing that's on there, and you're going to go ahead and attach it onto the panel stopcock here on the lumbar drain setup. And then next you're going to want to turn the panel stopcock off to the patient tubing here. So it's not going to be hooked up to your patient yet like this drawing, but you want to turn it off to the end of the tubing. Next you're going to open a sterile saline and you're going to attach it to the patient stopcock here on the open port, and you're going to turn that stopcock off to the drain. And then from here, what you'll do is you'll flush with the saline just a little bit out to the end of the tubing here. Again, it's not going to be hooked up to your patient at this point. Now at this point, you're going to want to turn the patient stopcock down here and turn it off to the end of the tubing. And then go up to your panel stopcock, and now you're going to want to turn it off to the drain itself. And you want to go ahead and flush now with the saline down the tubing, and this will cause it to come all the way up and out the end of the transducer here. So once it's dripping out the end there, then you've got that primed enough. At this point, you would then replace the cap that's on the end with a non-vented cap. Then you would turn this panel stopcock off to the transducer here and continue flushing with your saline so that it goes all the way up and drips into the drip chamber here. Finally, you'll go back to the panel stopcock, turn it back off to the drain here, and go ahead and clamp. There's 3 manual clamps along here. Go ahead and clamp those to ensure that none of the fluid will drain back out. Then you'll take your stopcock down here, turning it off to the open port, taking your sterile saline syringe off and replacing the non-vented cap on there. At this point, your system is primed and ready to go, so you can go ahead and attach it to the end of the lumbar catheter that's coming out of the patient. Again, make sure that we're doing a betadine scrub, a good 30-second scrub, and then attaching the end of the tubing to the end of the lumbar catheter. Once you've done that, then go ahead and unclamp these 3 manual clamps along the way. So now that you have the patient hooked up, the first thing that you're going to want to do is level and zero the drain. At this point, you should have your panel stopcock, which is currently turned off to your drain, and you want to go ahead and take your laser level, and it's going to slide. You'll see there's a notch that will allow it to slide right into the drain here. So go ahead and slide it in so that the end is obviously facing towards the patient. Then you want to go ahead and take your pressure monitoring cable, attach it to the end of the transducer here, and then run it up and plug it into your monitor here. When you do so, a new pressure option will come up on there. You want to select the label for that, and that you're going to want to select as ICP. So even though we're going to be using this to monitor your spinal cord pressure, the only label that we're able to use on here is going to be for ICP monitoring. So just go ahead and select the ICP monitor. The appropriate type of waveform monitoring should show up here. Then what you want to do is you want to take the laser, and if you twist it, so you kind of twist it around in the holder here, that will activate the laser and turn it on. And so we're going to use this in order to adjust the height of the drain on the IV pole, or possibly the height of the bed, so that the laser, the level is shining at the level of the lumbar drain insertion site. So it's really important that you roll your patient, see where that insertion site is, and then make a mark on the side of them so that when you go to re-level and zero, that you have a mark and you don't have to turn them each time. This also will allow you a good opportunity to look at and assess that insertion site. Now, when you're doing the leveling of the zero, it's really important in the middle of the laser, you're going to see a bubble, and you want to make sure that bubble is lined up in between the 2 lines so that you know that it is actually level and the laser is going to be at the appropriate level that it's supposed to be on the patient. Now, once we know that we have the laser leveled at the insertion site and we are still off to the drain on the panel stopcock, what we want to do is we want to drop the drip chamber down to the 0 level. So up on the drip chamber up here, there's going to be another twist lever here that you would twist and untwist to either tighten or loosen and be able to raise and lower your drain. So what you're going to want to do is lower your drain down until you're at the 0 mark on here. Then what you're going to do is you're going to turn your panel stopcock off to the patient here. This way you're running from your transducer up to the drain. And this is where we're going to be getting our quote-unquote open to air. We're never going to take the cap off the end of the transducer here. We simply adjust the panel stopcock so that we're going from the transducer to the drip chamber. Again, remember, we want to minimize how much we're opening this system, so that's why we would not remove that stopcock on the end there. Now, once you've got it off to the patient, your drip chamber is down to 0, then you want to hit 0 ICP on your monitor. Once it shows 0 onto the monitor, then you want to bring your drain height back up to whatever the value is that they have set for your patient. Typically, the physicians are going to order this to be at 10 centimeters of water. And again, if you remember, I said that we're going to have both centimeters of water and millimeters of mercury. So it's really important that you're using the right scale. And the reason for this is at 10 centimeters of water, you're at 7.4 millimeters of mercury. And basically the way that this drain works is if you have it set here at 10 or the 7.4 millimeters of mercury, in order for anything to drain out of your patient and into the drip chamber, there's going to have to be a greater spinal cord pressure that's above 7.4. So anything above 7.4 will then spill over out of the patient and into the drip chamber. Okay, so once you have the lumbar drain leveled and zeroed, the next thing we're going to want to do is record our spinal cord pressure and our spinal cord perfusion pressure. So in order to do that, we're going to have to turn the panel stopcock off to the drain. And this way now you're open from your transducer going down towards your patient. And as soon as you do that, you'll begin to see a waveform appear on the monitor. You're not going to have a true waveform with it being a spinal cord pressure, but you're going to see, squiggly lines, kind of similar to, how you might see your CVP. And this just ensures that you are getting an actual spinal cord pressure by doing this. But you want to allow it a minute in order for the numbers to level out, and then go ahead and record what your spinal cord pressure is. At this point, go ahead and calculate out your spinal cord perfusion pressure. So again, if you remember, your MAP minus your spinal cord pressure. And you can have this set up to automatically happen on the monitor. What you need to do is activate a new measurement, and in doing so, one of the options that you can choose from is CPP. Now, typically the measurements on our monitors are for our EVDs, so your ICP, intracranial pressure, and your CPP is your cerebral perfusion pressure. But these numbers are going to essentially work and give us the same numbers that we're looking for with our spinal cord pressures. So our ICP is going to be what we're looking for, our spinal cord pressure, and our CPP is what we're going to be looking for our spinal cord perfusion pressure. In order, though, to make sure that you can activate and use the CPP appropriately, you just have to make sure that the label that you're using for your art line, so whether it's ART or ABP, when you're setting up this measurement, that you select the right label. And if you do so, then whenever you have an ICP reading, it will automatically calculate out your CPP for you and save you from doing that calculation. Not that it's that hard, but it will just display it right there on the monitor. Now, every time you do your spinal cord pressure and spinal cord perfusion pressure calculations, you want to make sure that you write them down. So sometimes the values that are being pulled in at the time that you did your check are not going to be in line with what you wrote down, and so you're going to need to change them. Other times it's going to be pulling in values that were not from when you were doing your checks, and those are just going to need to be removed from the charting. All right, so now that we've gone over getting it set up, how to level and zero, and to get our spinal cord pressure, the last thing we want to do is set this up into being able to drain. And typically our lumbar drains are going to be ordered to be open at 10 centimeters of water. And this is going to mean that the drain is going to be continuously open to draining for the patient. And the only time it's not going to be draining is if we're leveling it and zeroing it, or if we're recording our spinal cord pressure measurement. So in order to drain, there's really two ways that we can do it. We can either turn it off to the transducer or off to the open end over here. If you turn the panel stopcock off to the open end, so this way your stopcock is open to the transducer, the patient, and the drain. If you do that, you're still going to get an ICP reading that's showing up on your monitor. The only thing is it's not going to be entirely accurate. And this is where I was talking about if values are being pulled over into your charting that are not correct, that they're going to need to be removed. But we suggest that you turn it off to nothing over here so that you still do get a reading showing up on your monitor. And the purpose for this is you'll be able to see trends. So even though the number isn't going to be accurate, you will be able to see trends if the values are increasing. So instead of being completely oblivious to whatever the pressure is until your next hourly check, you will be able to see that increasing pressure, and you can come in and spot check what your pressure is periodically if need be. All right, and finally the last thing that I want to talk about with the lumbar drain setup here is the removal. So an important thing to know is only anesthesia or a surgeon will be the one to remove the lumbar catheter. You want to have the patient lying on their side. They want to have their knees up and their chin tucked down to their chest. You want to take the drain and turn it off to the patient here. Once they remove the catheter, you want to assess the tip of it for intactness to make sure that there wasn't any fractured catheter that's left inside the patient. And finally, you want to have the patient lay flat for 1 hour. After they do that, then they're able to move freely however is ordered by your provider. So like I said, with all of this, I am going to make a separate set of actual videos going over these different steps, but I just wanted to kind of talk through them right now just to give you the basic understanding of what you're going to do with each of those with the system. All right, so now let's move on to talking about some of the nursing interventions for taking care of these drains, as well as to talk about the documentation that is required. So the first thing that you want to be doing is you want to be checking your spinal cord pressure and your spinal cord perfusion pressure hourly. Now you want to check your orders and see what they have ordered for your patient. But typically, if your spinal cord pressure is greater than 10, then you want to troubleshoot it. And if it still is above 10, then you need to notify the physician. In order to troubleshoot it, you want to look for things like, do you have any kink tubing? Check your stopcock position. Do you have the clamps, the manual clamps engaged? You want to take it and re-level and zero it to make sure that that's right. One thing you want to note is if you have had the drain clamped for a little while and it hasn't been draining, that you want to allow some drainage to come off first and then recheck your spinal cord pressure. So again, remember, reducing the CSF is what reduces our spinal cord pressure, so that may be the problem. If you're still, despite all this, you're still getting a high reading for your spinal cord pressure, but you're not sure if it's accurate, What you can do is, if you make sure that you have the proper level and zeroing, you can take the drip chamber and adjust it to the height that corresponds with the pressure that you're reading. And you want to do this with the blue side, the millimeters of mercury. So if you're getting a spinal cord pressure of 20, raise the drip chamber up to where it's at 20 on the millimeters of mercury. And again, if you remember, we talked about in order for it to continue to drain and drip, the pressure in the spinal canal is going to have to be above what that level the drain is at in millimeters of mercury. So if we have it set at 20, if your pressure is at or above 20, then it should drip. And so if you raise it to that level, or just below whatever the reading is that you're getting, and you still continue to see it drip into the drip chamber, then you know that that is true and that is what your spinal cord pressure is. Now, also, if you have a spinal cord perfusion pressure that's less than 80, you again want to assess and make sure that your spinal cord pressure reading is right. If it is related to the patient's systemic blood pressure, if you have pressors available that you can use to increase the MAP, that will help with that as well. But for either of these readings, if either your spinal cord pressure is greater than 10 or your spinal cord perfusion pressure is less than 80 for more than 5 minutes, then you're going to need to contact the physician. And we want to be looking at CT surgery, vascular, as well as anesthesia. So the next intervention that you want to do is you want to monitor and record your drainage hourly. So again, like we talked about with your orders, you want to keep it open unless you are repositioning or ambulating the patient. And it's important that if you are doing any of these, that you do turn the drain off to the patient, so that way we don't get excessive drainage by accident. You want to not allow over drainage. So again, this is going to be no more than 20 mLs an hour or whatever is ordered for your patient. This may require frequent checks if there is a lot of drainage coming. So you want to look for any change in your CSF, so whether it's the color or clarity. And if you do notice any change, you need to notify the physician. You also want to watch for if the drainage were to stop. If the drainage does stop, then you need to troubleshoot it. And if you're not able to solve the problem, then you need to notify the physician. So things you want to look for in troubleshooting this is, was there a disconnect anywhere in the system? If there is something that is disconnected, know that the system is no longer sterile and you're going to need to set up a whole new drain setup to be used on this patient. You also want to check your clamps and your stopcocks to make sure that they're in the proper position to allow for drainage. If you've checked all that and it's still not draining, you can lower the drain down to 0 and check for any dripping or draining of the CSF at that point. If it does start dripping, immediately take it back to the level that you have it set at. If at 0 you're still not getting any drippage, you can further lower the chamber or raise the bed to adjust the level to see if you can get more drainage at that point. Again, as soon as you get drippage showing that it is working, then go ahead and set it back to the level that you're ordered at. Next, if none of this is still working, there may be a clot within the lumbar drain catheter that's causing the issue. If that's the case, then you can aspirate no more than 2 mLs of CSF. And you would do this by attaching, again, using sterile technique and betadine 30-second scrub. You can attach a syringe to the patient stopcock and then slowly and carefully aspirate no more than 2 mLs of CSF. And this could potentially dislodge any clot or anything that's within that catheter. Finally, if the drainage has been bloody, or you notice any clots or precipitate within the lumbar drain setup, the tubing on there, then you can flush that tubing, and you're going to want to flush this towards the drain. So again, remember, we never flush it towards the patient, but you can flush again using sterile technique anywhere from the patient stopcock all the way back to the drain in order to clear that out of the tubing, and perhaps that will help with the proper drainage. Again, if you've tried all of this and none of this is working, it's imperative that we contact the physician and let them know, because we're no longer getting the drainage that we need from this system. So we also want to be assessing the insertion site. And this, we're looking for any redness, any swelling, or any drainage. And this is why it's important to have that clear dressing on there. You also want to be doing your neuro checks. And per policy, you have to do at least every 4 hours. I would honestly suggest that you do every hour. That way, if there are any changes, you can notice them immediately. But you also want to be watchful not only for neuro changes, but any signs or symptoms of meningeal irritation. And this is, again, something we would call the physician for. But with this, you're looking for stiff neck, headache, vomiting, any change in their level of consciousness, or photophobia. And this could be a sign of some sort of irritation to the actual meninges. So the next intervention I want to talk about here is clamping. Now this one's important because you do not want to clamp any more than 5 minutes. The only time that you would clamp longer than this is if this has been ordered by the provider. Finally, prior to DCing the lumbar drain, they'll do a clamping trial. And this will oftentimes vary based on who is doing the trial. Sometimes they will clamp the lumbar drain for a few hours, and if the patient tolerates it, as in no neurological changes, then they will DC the lumbar drain after that. Sometimes they will clamp it and keep it clamped for 24 hours or more, and this way we can continue to assess how the patient is doing without draining the CSF. And if something were to change, we simply have to turn it back to draining instead of having to place a new lumbar drain. So another thing with patients that have the lumbar drain is typically we will have them on bed rest unless they put in orders for them to ambulate. And we can ambulate the patients with the lumbar drains. We do need the order for it. And you just want to make sure and have it clamped off to the patient during ambulation. Also, if we are getting these patients up, they absolutely will need staff assistance in order to do that, to ensure that that drain does not get dislodged. Also, while the patients are in bed, we want to have the head of bed from 35 to 45 degrees. Also, with these patients, you want to make sure that you are assessing the drain level, that you want to do this at least hourly or with any patient movement or repositioning. You also want to zero your transducer, and this will do every 4 hours. Finally, if the drainage bag is to become more than 3/4 full, then we want to change that. So we're going to change the drainage bag. That needs to be done sterilely, and then you want to document that in the chart. So like I said, if it's 3/4 full. All right, so now that we have covered most of the major nursing interventions in caring for patients with lumbar drains, we're going to move on to the last part that I'm going to talk about. Everybody's favorite section is documentation. All right, so with our documentation, there's a few things that we need to be documenting hourly and a few things that we need to be documenting every 4 hours. So the things that we need to do hourly, these are going to be getting your spinal cord pressure and your spinal cord perfusion pressure. You need to be documenting vitals at least hourly. You need to get the color and the clarity of your CSF fluid, the amount of drainage, and depending on the frequency that you're doing your neurochecks, you're either going to do these hourly or every 4 hours. My suggestion is do your neurochecks hourly. Now, as far as the documentation every 4 hours, you're going to assess the insertion site, as well as your dressing integrity. And again, if you pull up the policy and procedure, it will talk about everything that you need to do in terms of your care, as well as the documentation of the lumbar drain. So that concludes everything that I want to talk about in regards to the lumbar drain, why we have patients that need a lumbar drain, some of the anatomy and pathophysiology behind why we use them, as well as the interventions, complications, and documentation that you're going to be responsible for as the bedside nurse. Again, I will be making another set of videos that will demonstrate the setup, leveling, and zeroing, recording your spinal cord pressure and spinal cord perfusion pressure, as well as the proper way to set it up in order to drain for the patient. That will all be included in a separate video for you guys. Otherwise, if you have any questions at all, as always, do not hesitate to ask me, any of the other managers, any of the other nurses that you're working with that have experience with these. And as always, make sure you guys are comfortable with what you're doing. If you're not entirely sure, make sure you find somebody, get your questions answered. There are very serious complications for these patients if these lumbar drains are not managed appropriately.